hidden areas, you remember them, and the disease involving multiple areas of the chest. Okay. And we started this aba kose pe wanuze kunyandikira y'Ubutare arahari, arafata arahari ya Jennings. Hello, abantu bihuye barahari?
Turahari.
Arafata nawe arahari? Ama nyekira SMS nkaho atazingira. Sinzi ko hari, sinzi ko bose babizi cyangwa ha Jennings bakeya gusa. Abo muza umuyobozi wanyari. Let me call him. Sepe wanyu ko ari ikibazo gikomeye. We ngo ntabwo yarazi ko twatangiye kandi namwandikiye isaha nambwiye ko saa yine dutangira ngo yategereje ko mbwira ko twatangiye. Igitangaza. No, so let us continue. Nta kibazo. So these slides we saw them last time. But the most important, we say that we will see the opacities of airspace or alveolar opacities, airspace opacities or alveolar opacities, interstitial opacities. Have you read the second pulmonary lobular anatomy? Hello?
Yes.
Yes, Prof.
Mwaisomye, who can tell me? Ntagira umuntu umbwira about it. Uvuze ngo yes nambwire rwose. Mbwira wasomye iki? Second pulmonary lobular anatomy. Wumvise iki? Because this is very important kugira ngo mwumve bino bintu tugiye kujyaho. Tell me. Ntagira umbwira ibyo yasomye twumve. No kudasubiza vuba vuba nkeka nako mutabisomye kuko ugiye kujya muri Google ugiye kubisoma insomere nkusoma binuzaye muri yo kwa padri hapana. So we will talk about airspace opacities tangiye kundakazi. Interstitial opacities and opacity due to collapsed lung, part of the lung. You can see, we'll see a focal mass or nodule, how it looks like, if it is just one nodule or multiple nodules, and we see some opacities related to pleural or pleural spaces. Okay, that's what I want. So for airspace shadowing or consolidation, we said the difference between alveolar opacity and consolidation. Okay, who can tell me? What is the consolidation according to what I said last time? Is there a Salomo is there? Urahari? Tell me what is the consolidation? Mm. Mm-hmm. Mm. Eh? Uh-huh. Within the rank uvuze iki ubwo? Ntabwo nakumvise. Byacitse ngira. Mhm. Uh-huh. Mm. Mm. Fluid where?
Sorry. Sorry.
Within the lung. And when can you in your report say this is pneumonia? When can you use consolidation? When can you use pneumonia? When can you use, I don't know. Mm-hmm. When? Ah, anything ryari uzavuga ko ari consolidation, ryari uzavuga ko ari pneumonia? Nivyo nikubaza. That's my question. When can you confidently say this is most likely pneumonia, or just use this is consolidation? Are they the same, by the way? Man, sign. What's the sign?
Actually, we have
Yes.
seen that we use the term consolidation if we don't know exact if it is pneumonia, if it is another thing, if we are not ready to confirm.
Yes, I said just consolidation. It's a collection of fluid in the lung. That's one. But that collection can be caused by can have different causes. Okay? Trauma, pneumonia, any cause of fluid collection in the lung. That's the consolidation. So from there now, if you add in the clinical history of the patient, you can say, this consolidation now is due to it's pneumonia. It's due to pneumonia, it's due to TB, it's due to another pathology. Okay? Wabyumvise Izere Salomo? Wari uhari se ubushize? Wari uhari? Usanzwe ugira iki kibazo se? Cyangwa nikije uyu munsi? Nk'icyo ngicyo wari ufite? Ko utumva neza. Icyo kutumva neza kirasanzwe, okay? Dufite ivuriro hano hirya Kigali. Ifite akavuriro kavura ibyo bintu. Uzaze tukuyobore. Okay, so let us continue. Nitwa Karayesi hano hirya ruguru. Okay, so I'm just joking. Nizere ko utari urakare ngo nakubwiye ngo wasaze. Oya ni ibisanzwe. Ntabwo wari wabyumvise cyangwa wabyibuye. No problem. Okay, so airspace shadowing or consolidation. Munkurikira agira ufunguye microphone.
Shit.
So these are equivalent terms. Nonasubira mbyo twarebye ubushize. Equivalent terms, and it's caused by fluid filling the smaller bronchi, bronchioles, and alveoli, the lung. So the nature of this fluid cannot be determined on the radiograph, but could be pus infection, water, as in pulmonary edema, hemorrhage, for example, in some of the inflammations, malignant cells in alveolar carcinoma. Nabwiye ko igisa neza na consolidation, it is what we call bronchoalveolar carcinoma or proteinaceous fluid. So correlation with clinical settings nibyo nabwiraga is required to narrow the differential diagnosis. The hallmark of consolidation twarabibonye ko it's Air-Brongram sign, twarabibonye kandi tuzi niyo ariyo, ntabwo mbitindaho, twari twabirebye. I've seen this, and even this image you have seen it. There is an opacity that has some Air-Brongram signs within it, and that's what they wanted to show, but to say that there is another well-defined, well-marginated mass or opacity, not mass. Don't use mass when you are describing opacity, right? Parahyla, but there are other micronodular opacities. Can you see them? Micronodular opacities in the right lung. I can see them. This is not normal. I hope you have with time. It will come with time, but you have in your mind image of a normal chest radiograph, how it looks like, how the vessels look like. Okay, so that when you see something different, you will know there's something wrong. Even if I don't know, but there's something wrong here. Okay, so but here they want to just show that there is an opacity in the left lung, the whole left lung, by the way, with Air-Brongrams. Even here there is Air-Brongram because there is an opacity, but also there is tubular structures filled with air within it. So this is also an Air-Brongrams. As you can see on this image, there is trachea. But the trachea, as you see, it is deviated to the left side. Okay? Yeah, you can see that it is not central. It is pushed, it is deviated to the left side. And when you see any structure deviated to the left side, to one side, immediately as a medical doctor, as someone who is interpreting the image, you should ask yourself, why? What's the cause? What is the cause of this deviation? Like here, is it a disease? Is it a pathological process? Or is it technical? For me, like here, I can think maybe there is a small rotation, slight rotation here to the left side, because the distance from here to this one and from here to there, the left side, the distance is bigger on the left side. So there is a rotation. And remember, I told you that where the distance, the bigger distance is, it is where the patient was rotating to the side was rotating to. So the patient was rotating to the side, the left side a bit. But the way the trachea is deviated, that level, it is too much to let this deviation to this rotation. Another reason may be it is this opacity that I consider as a mass, maybe pushing on the trachea. That's maybe another reason. And the third one, what I don't believe much, but may be possible, I don't know if there is any kind of lung fibrosis in this opacity pulling on the trachea. Those are three possible causes of this trachea deviation. Okay, that's how we think, and even not even a trachea deviation. Even the hemidiaphragm on the left side is pulled up. Look, the level of the hemidiaphragm. This is gastric bubble. The hemidiaphragm is pulled up compared to the right one. Right one is down, even if it was cut off. But the left one, remember, it is one who was supposed to be at the lower level, but is up. Eh? I see this deviation with trachea, immediately I have to look for solutions. I see this elevation of the left hem diaphragm. Immediately I say, why? And the answers of those whys, they are the ones which will help me to know the diagnosis. Like now, by seeing this elevation of the left hem diaphragm, I immediately think and almost confidently that there is something here in the left lung that is pulling on the hemidiaphragm, even on the trachea. Because this hemidiaphragm cannot be up this level without any cause here in the left lung. Okay? Are we together? Hello?
Yes.
Rajana Neza?
Yes.
That's how we interpret, by the way. Mm. So we saw even these images with this chest radiograph. It's a PA by seeing where the location of the scapulae is retracted towards the lateral side, and you can see an opacity. That is for sure airspace opacity, all alveolar opacity with air bronchograms. That's what they want to show, by the way. By magnification, you see these air bronchograms within it. But here also you can see it. You can see the air, the bronchi within it. But we are sure that this opacity is limited by a fissure. That is horizontal fissure, considering the location of this limitation of the opacity. Normally, the horizontal fissure comes from the right hilum to the periphery this way. So this is a limitation by the horizontal fissure. And immediately we not use the opacity, we not say that the opacity is in the right upper zone or something. We are no longer using the zone. We are sure about which lobe the opacity is. So it is in the right upper lobe now, not zone. And we know it is airspace opacity because it is an opacity with air bronchograms. It's a consolidation. Now the rest will be to know the clinical history of the patient. That's the reason why, by the way, we always request, as radiologists, we always request clinician to mention the clinical information of the patient. Because if I see this without having clinical information, clinical history of the patient, I will just, in my conclusion, I will just say there is a consolidation of the right upper lobe. And consolidation doesn't mean much. If I had chest pain, fever for 2 or 3 days, immediately I will conclude that this is pneumonia. Okay? But without clinical history, I cannot say this is pneumonia. No. You see? So this is right upper lobe consolidation. Okay? And we haven't seen this. There is a patchy. Patchy, remember what means patchy? Patchy is something that's irregular. Patchy opacity in the left lung. But I can even go far and say it is in the left lingular segment because it is silhouetting the margin of the left heart, sign positive. It is alveolar opacity or airspace opacity because I can see some air bronchograms within it, some air spaces within it. So I'm very sure that this is the airspace opacity. And I'm sure that it is in the left lingular segment, So it is a consolidation. If we add some clinical history of the patient, I will either call lung, I can call it according to clinical history, pneumonia or lung contusion or anything else if you try to relate to the clinical history of the patient. Okay. This one, so this is a well-defined mass or nodule, parahilar, because this is hilum, this is parahilar or perihilar within the hilum. Well-marginated, homogeneous opacity. But we saw another one here, another small nodule, homogeneous, well-marginated. The rest of the lungs are okay. Costophrenic angles are good. The size of the mediastinum is fine. This is aortic arch. The size of the heart is okay. Remember that before even I comment on it, on this image, I have just seen immediately that this was not a deep and spirited film, because look, you cannot count 6 anterior lips. Yeah, they're like 1, 2, 3, 4, 5. The 6th one is there, and the midclavicular line is this. So this is not deep inspiration, I'm sure. So the heart, it cannot go beyond the half of the heart, though it was not deep inspiration. So my question is, can it be airspace opacity? For me, it doesn't look like airspace opacity. It's not normally airspace opacities. They are irregular. They have irregular margins, but this one is smooth, well marginated, homogeneous opacity. It looks like a mass nodule. Even this one is nodule. Okay. Lung nodules may have various different features. However, they will typically not observe the boundaries of normal anatomical lung, such as the right sided nodule. So it doesn't look like airspace opacity. It can be either right hilar adenopathy, but when you see this, it can be lung masses, tumors. When I see this, I go straight forward to the CT scan with contrast of the chest, CT chest with contrast, to better characterize these nodules and see what they are. On the left side, on the right side, we have another irregular or patchy opacity with air bronchogram. But also someone told me that there's some linear or reticular opacities within it. It's not that typical to, but it looks like airspace opacities. Airspace opacities. And remember this, I told you bronchoalveolar carcinoma can look like consolidation. This was the case of bronchoalveolar carcinoma. It's the only carcinoma that looks like consolidation. So don't say how can you differentiate them. It's still always clinical history. Because if you give this image and you tell me the patient is sick for 3 months or 4 or 6, coughing, chest pain, for weight loss, I not to go and say this is a consolidation. No, immediately I think of something, chronic disease. That is chronic disease. There is no consolidation that can be there for 6 months or 3 months. Okay, is it okay? Good. That's how we approach these different opacities. So twatugeze ahangaha. That's where we were last time. So let us now see, unless you have any question about ubu turagenda neza buhoro, we go slow, like ntabwo ndi bwirukanye cyane, because this is now what you have seen before. It was just some principles of, but now we go into details now. It's somehow practical. So for airspace opacities, hari umuntu ufite ikibazo? Do you have a question? Mugira ibibazo bike namwe. Ibisubizo bike ariko byose. So any question? niba ntabyo Imana ishimwe igende ikomereza. Okay. So we have just seen airspace opacities or alveolar opacities. We go now to interstitial shadowing opacities. Shadow opacity is the same. Interstitial. That's the reason why I was asking you to read about second pulmonary lobule. Mwambeshe mwarabisomye mbabajije mu buri gisubizo. Mwese mbona ibyo ari byo. Ariko utanabisomye nta kazi ke ko muri abantu bakuru. Hano muri imyaka 15 hano muri mwe. I don't think so. Niba mutarabisomye n'akazi kanyu n'ubundi bintabwo muri bubyumve neza. So the interstitial space is a potential space that surrounds the bronchi, alveoli and vessels. Narabivuze ko in the lungs there are alveoli, but they are separated by what you call connective tissue interstitium, where pass the bronchi, where pass the vessels, blood vessels, lymphatic vessels. When you say vessels, blood vessels, veins, and arteries. Okay, that's very important to understand, because if you see interstitial edema or any process, even in asthma, when you know the pathophysiology of the disease, you will immediately understand how it will appear on chest radiograph, where we locate the process, the disease. Okay. When there is disease in the interstitium, it manifests itself by reticulonodular shadowing. Okay, there are three, maybe but normally in interstitial space, there are different type of opacities due to different causes or diseases. Number one, you can have linear opacity. When you say linear opacity, it is caused by, most of the cases, by interstitial process. Reticular, nodular opacities or reticulonodular opacities. Those are different opacities that can be seen in interstitial process. Okay. There are two processes affecting the interstitium. First, accumulation of fluid, which occur in the pulmonary edema, okay, or in lymphangitis carcinomatosa. When it's carcinomatosa, it is just some cancer cells that are located in the lymphatic vessels. And remember, lymphatic vessels in the lungs. Lymphatic vessels also, remember, they pass through the connective tissue, that's the interstitium. Yeah, okay, that's one. Accumulation of fluid, either by edema, pulmonary edema, what you call pulmonary interstitial edema, or in the lymphangitis carcinomatosa, that's invasion of the pulmonary lymphatics by malignant cells. Number two, it can be caused by inflammation leading to fibrosis, which has many causes, including idiopathic fibrosis, alveolitis, sarcoidosis, asbestosis. Those are different types that can cause the opacities looking like interstitial opacities, as you have seen them, either linear, reticular, or nodular opacities. Fibrosis is usually associated with loss of volume loss. That is the key information you have to remember. You cannot just say this because it is linear or reticular, it is fibrosis, unless you have the second sign, that is volume loss of the lung. Okay, so we have two images. Let us start by the left one here. Okay, which type of opacities do you see on this one? What are you seeing here? Is it linear opacity? Are they linear opacities? Are they reticular? Are they nodular? What do you think? What I'm sure of is that these opacities I can see, they are not alveolar. That one you are sure. When you see it, before even you think, these are interstitial opacities. But now we go for and say which type of opacities I can see. Mm-hmm.
Reticulonodular.
Can you see some nodules within it? I don't see nodules within these opacities. I want you to open your eyes
Yeah,
and try to know how to recognize them. Apparently, I don't see the nodules.
Actually, there are.
I see the leticular. It's like mesh leticular. Leticular means leticular it's just leticular in net. Yeah?
Lecture ariko
Net.
harimo n'utundi tuntu tumeze nk'utunodule.
I don't see them. Je namba ndani net nvuga nona bigira binini ntago mbibona. I can see just this is typically, but I understand you. Maybe can you compare there and here on this?
Yeah.
Are they the same?
Aha ngaho ziri kugaragara cyane.
So for me, listen. For me, this is reticular opacification of both lungs. Reticular. I don't see nodules. I could be with time. Should come with time. But these are reticular opacities. Reticular opacities. Or reticular opacification. When it is diffuse, you can even say reticular opacification of both lungs. Okay? The same as here. Even here, it's not, I don't see nodules. They are just reticular opacification of both lungs. Diffuse reticular opacification. They are reticular opacification. Yeah. Okay? So for these two, for me, it is reticular opacification. But another one, note the difference between this pattern, which is essentially a meshwork of lines, and the more confluent patchy airspace. Aravuga nk'ahantu byegeranye cyane ugasanga hari igihe reticular, reka mbibabwire mu byumve neza, in some processes, reticular opacities can be confluent and look like airspace opacities. It happens. They are confluent, even if they are interstitial opacities. But when they are confluent, they look now like irregular alveolar opacity. It happens. Okay, that's a very important message, by the way. Because remember, by recognizing opacities like either they are interstitial or airspace opacities, from there, you start now thinking about the differential diagnosis. Since you are not able to recognize opacity like interstitial or airspace, you can't really, you become stuck. You can't go far. Okay. So look at this one. Let us start by the first one. For this one now, can you see that now they are no longer, it is even nodular, reticular nodular, because and the prominent opacities are nodules. Okay. You see, they are much nodules. What I have just said, can you see this area here? These are these interstitial opacities, but here they are confluent and it looks like it is alveolar airspace opacity. But now it is a confluence of interstitial opacities. Now it becomes like airspace opacity, alveolar opacity. But otherwise, they are nodular opacities. Can you see this?
Yes.
And when I remember something, I will tell you immediately. I will mix things, messages. The what you call silhouette sign, even if they are not completely obscuring the margin of the normal anatomy, but here there is a silhouette sign positive because the margin of the heart is not seeing very well. It's not very well outlined, even the hemidiaphragm. So the silhouette sign is still there. Okay. So this is not the opacity. How about here? byanditseho ariko when you see very well, this doesn't look like here. This is more of reticular nodular now. It's a mixture of reticular, like meshwork lines, and nodules. Ibi ndagira ngo mubirebe neza. Nicyo gikomeye mubirebe neza so that you can recognize images. Different diseases can give reticular nodular opacities. We know them. Others can give nodular opacities. Look like this, but most of the cases in our context is miliary TB. But here it's another disease, cannot be miliary TB. This is macronodular opacities, reticular nodular opacities, I mean. That can be caused by any other interstitial lung disease. Okay? Hari akabazo kari aha tutarakomeza? Any question?
I have a question. Kuri no first image ndabona silhouette sign itaba iri positive. Ndabona kuri no first image silhouette sign itaba ari positive.
Okay. It is okay. Kubera kwa kuibona margins.
Yeah.
That silhouette sign, it doesn't completely mean you can't see it at all. But that's not, by the way, that's not a very, it cannot affect your reading of this image. Silhouette sign is something confirming that there is an opacity. So it's important. But silhouette sign doesn't mean the normal anatomy is distorted completely. Right? There is, you can't see very well the margin of this heart on both sides, the diaphragm, because of these opacities. There are also silhouette signs. Okay, even here on this one. Okay.
Yes.
The silhouette sign, the meaning or the role of silhouette sign, it is to tell you that there is an opacity, abnormal opacity. Okay, any other question? I want you to differentiate this. Look how this look like. This is the reticular opacity. This is the reticular opacities. Okay. When you go to this one, yes. Ndakumva. Hello.
How is this image on the left only medular? Because I can see.
Network yanjye nimeze nabi. Is my network good or not?
It's good.
Good.
Mwebwe muranyumva neza?
Network. Yego ni ikibazo cy'ubwakeye.
Ikibazo cyanjye cyangwa ni cyanjye?
Ni ikibazo cye.
Ikibazo cye.
Kuko je muranyumva neza nta kibazo?
Yego.
Okay. Because nakoresha network itandukanye niyo nakoresha ubushize nibazaga niba munyumva neza. So ubwo se turamenye yashaka kubaza ngo yashaka kubaza, I think yabajije, she wanted to know, she said she can see this is not just nodular opacities. But it's a very good question, because normally when we are describing the findings, we prioritize the more prominent opacities, like this one. Even if in 90% of these lungs, they are nodular opacity, micronodular. They are micronodular opacities. But there are some areas where you can see like reticular here. Can you see? They are like reticular at that level. Even this one looks like the reticular. But in general, if I want to, in one word, if I want to talk about this type of opacities here, you say just micronodular opacification of the lungs. Even though there are some small areas where you have reticular opacities, but the prominent image, the prominent finding is micronodular opacification of the lungs. Okay. I can't tell here that this is reticular nodular. It's nodular. It's micronodular opacification of the lungs. This can even be caused by the confluence of multiple nodules and giving this kind of image, looking like alveolar opacity, looking like reticular, while there are multiple nodules confluent, they have given this kind of images. Okay. So, interstitial opacification does languish. I'm done. If you have any question, ask. If you don't, I continue. We go to another type of opacity. Can I continue?
Lecturer.
Lecture.
Yes, continue. Yeah, because I have a question, lecturer. I have a question.
Yes, please. Ariko mugire vuba vuba kugira ngo tudateka umwanya munini.
Yeah, lecturer, can you summarize for me, because I have a bad network. I haven't understood well how to differentiate interstitial from the consolidation caused by when there is inside of alveoli fluids. Yeah, I can't differentiate by seeing X-ray.
You can't differentiate what?
I can differentiate consolidation, which is inside the alveoli, and when there is opacity caused by interstitial, like a nodule, when it is in interstitium, and when it is in alveoli. By seeing X-ray, I can't differentiate.
Uzi kugira ngo usubize? Natangira kuri side ya mbere. Yawizwe. Muri make iki kibazo cyawe ndacyanze. Mwani baga. Ndacyanze kubera yuko nizere ko abandi bavyumvise. Ubwo nicyo cyane twaka nta bakurikira, ariko still you could see the images.
Question.
Please.
Hello.
Twese se ko aricyo dufite lecturer.
What causes nessus opacity?
No. Hari abantu bankurikiraga. Who can answer the question? Try to answer the question, kuko numviye ngo mwese nicyo mufite urabeshya. Naba navunikiye iki? Na kwiyahura none. Hano hari umugozi nawe ujyamo kabisa. Who can try to answer the question? Ko arambajije ngo ntago wumva kuntu they cannot differentiate airspace opacity from interstitial opacities. Bazana bareka mukaga umuko mwari mumeze nk'ikumbira ko nari meze. Who can try to answer? Ni atagira gusubiza, gerageza gusubiza uko wabyumvise. Cyane bari abankurikiraga babyumvaga. Sila, are you there?
Lecture, I have an answer.
Eh?
Lecture.
Yes.
The space opacity has the clear boundary.
Oh yeah, they are irregular. It's irregular patchy opacities. It's a large patchy or irregular opacity in the lung with air brongram. In your alveolar opacity and space opacity. But interstitial opacities, they are either nodular or reticular or linear or reticular nodular opacities. Hari ikindi rega nivyo nta kindi. None se sinashubije basi nanashubije kwanza. Nashubije?
Yes. Very understandable.
None ko mbabaza ntimusubize murabeshya tu. Nta kibazo ndabafatira hadi. So the number 3 as type of opacity is about collapse or atelectasis. Now the difference between collapse and atelectasis, most of they are the same, they mean the same, but when a big part of the lung, like the whole lobe or the whole lung, we use collapse. But when it is a segment or smaller part of the lung, we use atelectasis normally. Atelectasis is a collapse or incomplete expansion of the lung or part of the lung. This is one of the most common findings of chest radiograph. It is most often caused by an endobronchial lesion, such as mucus plug or tumor compressing the bronchi, or foreign body, such as in a child or a malpositioned endotracheal tube. Especially the tube goes to the right bronchi, main bronchus, and the left lung is not, it doesn't receive any air. And when it doesn't receive any air, now it becomes collapsed now. It can also be caused by extrinsic compression centrally by a mass such as lymph node or peripheral compression by the pleural space, pleural effusion. It happens when the lung is collapsed. It is either complete collapse or incomplete. And an unusual type of atelectasis is cicatricial and is secondary to scarring, TB, or status post radiation. Never having a scarring, it will now collapse the part of the lung. When the lobe is not aerated, it will lose much of its volume. That's very important, by the way, loss of volume, and collapse to a predictable location, depending on whether it is an upper or middle or lower lobe. Okay. Any question here? No. So atelectasis is almost always associated with a linear increased density on chest X-ray. are now segmental or subsegmental collapse. Okay, if a collapsed lobe is seen, it is important to try and look for the cause. For example, a large carcinoma or endotracheal tube. When you see a collapsed part of the lung, immediately it's not that enough to report that is collapsed left lung, collapsed left lower lobe. No, yes, that's it. But immediately you have to look for the cause, because the most important thing is not the collapse, but what was the cause. That cause can be removed if possible. So these are many. I have there are some messages, but when you go to the practice, it will become now easier. Aha. So this is an example of, can you see this image? When you look at this,
Yes.
don't forget the approach. Immediately you want to see first if the image, technically the image is good to be interpreted. Like now the collimation or centering was not good. The inspiration was not good. Even there was rotation, because to the right side, because if you try to, can you see the tracheal tube here? And listen to me, for the endotracheal tube, in radiology, it is well inserted when the distance from its tip to the client angle, that should be at least 5 centimeters. When it is within 5 centimeters from the tip of the tracheal in endotracheal tube and the carina, within 5 centimeters, we know that is over. They have to go and pull it again up. That's message now. It comes into my mind when I see this endotracheal tube, and immediately when I see this, I see that there is opacity here. It's not clear. Remember how we compare the zones. This part, right upper lobe, is opacified. That's one. Number two, I can see some air bronchograms as if it is air space opacity. Number three, very important, there is elevation of horizontal fissure. Normal horizontal fissure is like this. Remember, the radiology, we have to remember the anatomy, but there is elevation of the horizontal fissure, and that is very, very important sign. Very important sign, because it immediately tells me there is something pulling on this, because nothing I can see is pushing. The middle lobe and the lower lobes, they are clear. I don't see any opacity. I don't get any mass pushing, but I can see an opacity in the right upper lobe, and it is pulling on the horizontal fissure, meaning most likely this could be right lower lobe atelectasis or collapse. Can you listen? Can you get the way I'm approaching my the way we can not call it pneumonia, not call it a consolidation, but call it a collapse?
No.
You get no.
Yes.
I am trying to analyze and say, okay, I can see an opacity. Okay, I can see air bronchograms. So far at that level, calling it consolidation it's not a sin. I'm right, but I can also see elevation of the horizontal fissure. That's another new sign, an important sign that can change my mind, or can make me to think twice. Okay, is this horizontal fissure pushed or pulled? I don't see anything that is pushing it in the part of the lower part of the lung. I don't see anything pushing the horizontal fissure, but I can think of something pulling it because there is an opacity here. I cannot tell much details about this opacity, but what I can tell, it looks like it is pulling on the horizontal fissure. So I can even see endotracheal tube. Maybe this endotracheal tube has gone far from where it was supposed to reach. So for me, most likely, this is right lower lobe collapse because it is pulling on the horizontal fissure. There is an opacity, but it's pulling on horizontal fissure. Any question?
Yes, lecturer.
Mm-hmm.
Actually, I didn't get where the concept of ET tube and the carina and the tip and whatever.
No, I said in radiology, when after inserting the endotracheal tube, sometimes it is the only indication to do chest radiograph to see if it is well inserted or not. And in radiology, what we see, if I can even, you have to know it, even you, there is no need of sending, you will be doing it wherever you are. The tip of the endotracheal tube should not go and reach beyond 5 centimeters from the canine angle. 5 centimeters. Okay? When it is within those 5 centimeters from the canine angle, you have to go and pull it up. The patient has a risk being and go that endotracheal tube can go into one bronchus, and most likely it will be in the right one main bronchus because it's the one that's more vertical. Is it clear?
Clear.
Yeah.
A question, okay?
So it means that
abantu bari iruhande rwawe bavaneho zabo kugira ngo kuvuga ntibize gutya kuvuga ndi nta kibazo.
Victor, he was trying to mean is cographitis or collapse.
Okay, that's a very good question, by the way. Remember, in but there is also a complete collapse. Complete collapse air to it. Bronchi give some air. The bronchi, they still receive some air. It will look like air bronchium sign. But it can even be associated. They can even be associated. Both collapse and consolidation, whatever. It will, all of those will be differentiated by just clinical history of the patient. Maybe the patient has inflammation or infection. And when you do X-ray, you see this kind of collapse, but it doesn't rule out any associated consolidation or pneumonia. But also in collapse itself, you can have some air bronchogram, some bronchi receiving still air in opacity caused by collapse. Have I answered the question?
Yes, Doctor.
Good. Can I continue? I think so. So I told you there is a sentence you didn't catch. Look, I said here. Aha. Look, this one. I said when the lobe is not aerated, it will lose the lobe. It will lose much of its volume and collapse to a predictable location depending on whether it is an upper, middle, or lower lobe. That's what we are going to see. The right up each lobe, it collapses in a predictable way. Okay? That's what we are going to see. Now, so this diagram is just the same as what you have just seen. They are trying to draw this. They have drawn this. Look here, because normally the horizontal fissure is this from the hilum to the periphery. It's not straight. This one is like this, but now it has gone up. It has either pulled or pushed up. It was elevated. And remember, by elevation of this, look, I forgot to tell you, even the hilum, have you seen the hilum has gone up? You know, the hilum has gone up even at the same level of on the left side. And when you see the hilum on the same level, even upper than left side, you have to say, there is something wrong here. You see? So the horizontal fissure has gone up. Even the hilum has gone up at the level of the left one. So those are the signs of, that's the indirect signs of part of the lung collapse. This was right upper lobe collapse. That is how now the predictable way of the right upper lobe collapse. The right horizontal fissure has gone up, the hilum goes up, and they go more medially. And they are pulling on the mediastinum, the trachea, and even the horizontal fissure. The diagram highlights the direction in which the lobe collapses and explains the appearance on the radiograph we have seen before. Akantu mwakumvise?
Yes, Doctor.
Yes, director.
By being collapsed, it becomes now opaque. Can you see that the part that is collapsed is opaque? It's no longer aerated, it's opaque.
It's clear.
Aha, this is another second. Eh? This is another another opacity. And you can see that there is elevation of horizontal fissure. There is opacity now, it is homogeneous opacity of the right upper lobe because we know this is horizontal fissure. So we are very sure this is right upper lobe. And again, if you see very well systematically, the trachea is also deviated to the right side, the same side. Even the hilum is somehow elevated because this is the left hilum is here. The right one is somewhere there up at the same level. So those are the signs of lung volume loss. And here in this case, the signs of right upper lobe collapse. Okay. Those are diagrams showing the same. When you try to do the lateral view, it will show like here. Okay, clear? Note the elevation of the horizontal fissure allows caused by right upper lobe atelectasis or collapse. You can call it atelectasis or collapse. I remember I told you. So now let us go to this. Can you see? Don't read the text. Can you see this chest radiograph here? You have, can you see the opacity here? This is not normal. This opacity is not normal, but it looks like a alveolar opacity. Can see some air spaces, but you can see there is an opacity here. That is silhouetting the margin of the heart. But also there is another triangular opacity within the heart here at the base. Can you see? This is normal heart margin. The normal heart shadow is this, but there is a double shadow here. That is somehow more triangular than normal. This is opacity. So always when you see this opacity like this, think of right middle lobe collapse. When you see an opacity here, double shadow, triangular opacity with this line like this, think of left lower lobe collapse.
What?
Left lower lobe collapse.
Repeat lecture.
Left lower lobe collapse. This is left lower lobe collapse. How it collapses? It is right middle lobe collapse. How it is? It looks like. Here you can ask me to see the indirect signs of those collapses. I think it was due to the collapse was on each side. I was supposed to see some changes like volume loss on this side, but also remember on another side it is pulling, and another side, each side is pulling on the mediastinum. So you don't see much as volume loss because the collapse of the left lower lobe is pulling on mediastinum. They're supposed to pull, and the collapse on the right middle lobe is also pulling on another side. Ntabwo muri kunyumva?
We are hearing.
Question.
But not understanding very well.
Ask the question.
I didn't cut the difference between right middle lobe collapse and left right middle lobe collapse and left lower lobe collapse. I've seen that that opacity is in the middle, which looks like a triangle. But
like this one.
Yes. And I see the right middle lobe collapse.
Yes.
But left middle lobe collapse, I'm not seeing it. I'm not understanding how it looks like very well.
Sorry?
I'm not understanding how to see left lower lobe collapse. But the right lower lobe collapse, I see it. Right middle lobe collapse, I mean.
Urayibonayo? Can you see it?
Yes.
Ahubwo bigoye kubona because it is the one difficult to see because it looks like alveolar opacity. It looks like airspace opacity. You can call it pneumonia if you are not very careful. You can call it consolidation. But this one, another one is spine. The left lower lobe collapse is spine positive of the heart. Remember. None se uragira ngo tubihindure. Niko bimeze nyine se tubihindure tubishyire ku ruhande uzayireba neza ra. Listen. Umbese tubabwire bahindure Imana ihindure kutuzabihinde ngo bibone. You have to know that's how it looks like. It is spine positive with the heart. double shadow, triangular shape. That's how it's a predictable location of this left lobe collapse. Now that's how it looks. Bimenye nyine ko ariko uzajya ubireba n'amaso bimenye. But what you see, it is a double shadow through the heart, the left heart, and it has a shape, triangular shape. We turaza kureba izindi ngero zitandukanye. Muri radiology, in radiology, Silak, how are you?
Fine, sir.
Can you understand what I'm talking about?
Yes, I do understand.
I know. So, listen.
Question.
Radiology, it's not just something. Some things in radiology are not just, they don't come out easily. You have to search and you look and search and find. But
question. How are we going to differentiate this right middle lobe collapse from the borders of the heart? Right atrium.
No necessarily. Let me ask you a question. From the images you have seen already, have you seen right border of the heart making like this? With these angles, have you seen it? Really? Remember I told you, in radiology, you have to know the normal anatomy. Then when it is distorted, it comes out immediately and you search for the answer. Why is it distorted? Look, normally it was supposed to be like this. It goes this way, the border of the heart, but there is an opacity. It's clear. Small, but opacity. And in radiology, there is nothing small.
Yes, I saw it. I'm seeing it.
Okay, so can I continue?
Indeed.
You have to read this text. You read it yourself. Ntabwo arimo gusoma text, sibyo?
Yego.
Sinshaka gusoma. Twagiye muri practical things then. So these are the diagrams of the same images. We are going to draw this so that you understand what happened. Look, the left lower lobe collapse. It does this. It is always a triangular shape on the superimposed of the left part of the heart. It is always like this. That's a predictable fashion. And remember, for the collapse, they are homogeneous opacities in most of the cases. You know, it is more dense, more opaque, and homogeneous than even the heart. Maybe it is because of superimposition. They are superimposed with the heart, but it's homogeneous, well-defined opacities, okay? For the right middle lobe, it is always like this, rounds like this, and the contact with the heart borders on the right side. When you see homogeneous opacity, with this fashion, this shape, silhouetting in the margin of the heart, and in most of the cases, when they are not bilateral, you will see some indirect signs as pulling slightly on the mediastinum or even on the hemidiaphragms. Because if it is just one right middle lobe collapse, you will see the hemidiaphragm going up a bit, even the trachea or mediastinum going on the other side. The reason why we didn't see it on the previous image, the left lower lobe collapse was pulling towards the left, and this one on the right one pulling towards the right. It was a nil, one draw. Okay? Is it clear here? Can I continue?
Yes.
Good. Twagiye. Okay? So sometimes it is not clear as you are expecting it to be. Like in this image, don't read there. Just check the image. I can see a very good chest radiograph. Technical, it's good. And everything's fine from the technical. Those 5 things are okay. But what I see immediately, something that comes out without these arrows, it is the left hem diaphragm that has gone up. And immediately I know this is not normal. Either something is pushing or something is pulling up. And when you analyze very well, you see a vague opacity that is not supposed to be there. You see, there is an opacity here. Why here it's not looking like here? There is something wrong. And let me tell you the truth, it doesn't look like the previous image, but this was an incomplete left lower lobe collapse. It has still the same shape, triangular shape, but it is not completely collapsed. That's the reason why it is not opaque as we're supposed to see a collapsed part of the lung. But there is a reduction of air entry here, left lower lobe collapse. If they didn't put these alloys, you should not have seen, it should have been for you difficult to know that there is an opacity here. But we have a direct sign. This is a very important sign. And this is a fissure also that is, you remember the oblique fissure is like this normally in the, but it has gone, come down. That's what I want to show, that the fissure has pulled down. Horizontal fissure has been pulled down by this collapse. Ibi mwabyibaguhaye udashyizeho ikintu wabimenya. Can you know? Ariko at least wavuga ngo there is elevation, much severe elevation of the left hem diaphragm. That's one. And again, the cause. Is it pushed? Is it pulled? When you start thinking of like that way, immediately you will see that there is something wrong here. There is that oblique fissure that is pulled down. So most likely it looks like there's a collapse. And this is left lower lobe collapse. Is it clear? Is it okay? It is difficult, I know, but you get the message.
Yes.
Lecture. On the right lung, there is a tubular structure going through the lung, throughout the lung.
Tubular?
On the right lung.
The right lung is just, this is artifact. It's the catheter on the, no, sorry, on the skin. The patient had any catheter from maybe, and I don't know, something that was in the patient.
Okay.
It is not within. Now you have Gecko on front of you, you can't tell me that something is within the chest or out of the chest. But this is just out of the chest, on the body, on chest wall.
Okay.
Twagiye. Nuko bari kubishushanya, ariko who can tell me, umbaretse imagine mwambwira ikintu cyabaye. Tell me what happens here. Don't read, just go. The next time I remove this text. But I know you mukunda kopera mwebwe. Can you see this is a normal chest radiograph? I mean, it's good, technical, it's good. The heart is okay, the left lung is fine, the trachea. Immediately, you remember I told you that the approach from the center, mediastinum, to the periphery. Mediastinum, hilum, lungs. Why when you right? Can you see? Can you see? Washyizeho mic yawe. Ngaho tubwire, tell us.
Yeah, I have seen that the trachea has been pulled to right side. Trachea.
But before you say something, before you start analyzing, please make sure it's not due to technical issues. Please check the technical issues. technical qualities. Before you start telling the trachea is deviated, please, report here trachea is deviated while there is rotation. Rotation itself can the trachea being so like in this case, there is a slight rotation to the right side, meaning that deviation of the trachea in one part it's due to the rotation. Okay? That's the truth. Ugiye kureba neza reba spinous process zingizi, the distance here and this one they are different. So the patient was rotating to the right, the trachea being on the side, it's one part, even more than 60% is due to rotation.
Okay, but rector, I can see that
there is an opacity here.
Yeah, an opacity here.
There is an opacity here for sure. And that opacity, but don't jump on the interpreting these radiographs. Because if you're not systematic, you will mix and you can't end up by a good in a good diagnosis. Systematic, like start by the mediastinum, even if there is opacity, even if it comes out as opacity, but start by systematically mediastinum. Is it okay in size? 4S, size, shape, shadow, and sight and sight. Check the size, check everything. The trachea, is this central? No. Was it due? If you have started by technical qualities, you know, it may be due to rotation. Okay. And you go to is there any pathology of the vessels, great vessels? I don't see. The heart size is okay. Yes. Okay, let us do the hilum. Okay, the left one is there. Another one has gone down a bit. You can see it's no longer even, it's okay. It's acceptable. Let us see the upper zone. It's clear. The middle zone. It's clear. The lower zone. There's an opacity here. And that opacity looks like alveolar airspace opacity, because you can see some earblograms. It doesn't have much regular margins, but it's silhouetting in the right margin of the right heart. Okay, but what can it? Listen, there is a reason here. I continue. I can see the left lower zone is okay. It's clear. I don't see no opacity. Costophrenic angles are sharp. And I go to the bones. I don't see anything in the bone. But there was fracture. Can you see that there was a fracture here? Can you see that there was old fracture maybe of this. Why can you see?
It's difficult.
I should not just go fast and go to the opacity. Be systematic, my friend. You will see much more.
It's difficult.
Even me, I didn't know that there is. But I have been systematic with you, and I say there was a fracture. Okay. And I don't see anything else. The only thing, 2 findings or 3. First, there is deviation of trachea. I don't know if 100% due to rotation or not, but even downwards, there is still deviation of the trachea. Even the right main bronchus deviated the right side. There is this opacity here, and there is this fracture. But still, I'm confused as a medical doctor. Cindy, I don't want to be a witch doctor and say this is pneumonia. How? Maybe if there is a clinical history of fever, cough, and chest pain, I can say straightforward. Okay, it's most likely pneumonia, consolidation, pneumonia. But I know for this case there is cough and chest pain, but there is no fever. That was most likely the clinical history here. And what I can see is, another possibility is right middle lobe collapse. That's another possibility. Even if I don't have much convincing signs. How so? Let me, you remember on collapses, lung collapses, the lateral views are very helpful, useful, like check on the same patient when they have done the lateral view. Immediately it came out not as. So lateral views are sometimes very helpful. Like if you have a confusion, why not requesting for lateral view? In any case, not for collapse alone, in any case, you are not sure about location, you are not sure about what's going on, so request for another dimension, then that can add some more information and increase your confidence. All right. Mwabyumvise?
Yes.
Can you get how we think in radiology? That's how we think. We don't just invent things. We follow the mechanism, follow the normal anatomy, we add some clinical information, and you come up with something good. Okay? I will try to think with you later. Let me go to next one. Upper lobe collapse now. Left upper lobe, not yes. The left lung lacks a middle lobe, and therefore a minor fissure is not there. So left upper lobe atelectasis present a different picture from that of the right upper lobe collapse. The result is predominantly anterior shift of the upper lobe in the left upper lobe collapse with loss of the left upper cardiac border. Okay, the expanded lower lobe, that compensation. The expanded left lower lobe will migrate to a location both superior and posterior to the upper lobe in order to occupy the vacated space. Erigani ni ibintu bisobanutse. If the left upper lobe is collapsed, the left lower lobe will expand and occupy the vacated space upwards. As the lower lobe expands, the lower lobe artery shifts superiorly. That's good. And the left main stem bronchus also rotates to a nearly horizontal position. Shifted. Okay, those are just the words that can even explain the images we'll see. Aha, look, if I let me go schematically, just go to the opacity. If I check this, first of all, I know this patient is very sick, likely being into the ICU because of this material we can see on the chest. Okay, sorry. When I see this, immediately I say, in the area, most likely the patient is in ICU before even I'm told. And immediately, technically, it is bad, but interpretable, because I was not expecting to see any better image from the ICU. This is what was done using the portable machine for sure. And remember the effect. Number 3, if it is interpretable, let me try to interpret. The first thing I see is like the mediastinum. I immediately see that the mediastinum is deviated to the left because the border, there is no part of the heart on the right side. It is pushed. The heart is pushed, not pushed. It's deviated to the left side. I don't know if it is pushed or not, but I can see the mediastinum from the trachea deviated to the left. The main bronchi pushed and deviated to the left side, and I have started the interpretation in analyzing. Push the right, so the heart, the mediastinum itself, all the mediastinum is deviated to the left side. Another information is like, if I start now, the hilum, I don't see much, but it looks like the hilum on the left side is somehow elevated. Too much elevated. So at that level, it was supposed to be somewhere there, but it's elevated. And again, there is opacity somehow here. Near the mediastinum, it is not clear like another rest of the lungs. It is opaque here. All right? It's opaque. This area is opaque, and there is a deviation of the mediastinum, and the left lower lobe is now has gone up. What they are trying to explain. The left lower lobe has gone up. That's the reason why this opacity is not that opaque as it was supposed to be in a collapse. Because the left lower lobe has occupied the vacated space. And let me tell you the truth, by seeing this deviation, by seeing this elevation of the hemidiaphragm on the left side, I know the opacity here should be the collapse, something that's collapsing. And when I saw, I read this text now and try to think what happens, I can tell with confidence that this is left upper lobe collapse. Any question? If you are not sure, please request for the lateral view. The lateral view will be clear. We'll tell you what it is. By the way, I can request for the lateral view to see better what is going on. Any question here?
Question.
No question.
Question.
Mm-hmm.
For example, iki kibazo urugero kidaye nko mu kizamini natwe twa requesting for lateral.
No. I am expecting it to tell me that you needed you can request for a lateral.
Ko tubona nyine
banegeje ko ubivugiye ukavuga uti I have seen this.
Twavuga ko twabonye ama opacity kuko
I think of this, but a lateral view can help me. Ndegeje ko bivuga nyine. Banegeje ko mu kizamini bivuga nkuko wabitekereza mu kazi.
Okay. So, thank you.
Cyane ariko birenze kuba cyane. Uko utamvuga mutabaye umuntu kwanza ntagaze ibyo ari byo. All right? Komeze. Can I continue?
Yes.
Yeah.
We have 10 minutes to go. Minota kwa yose cyane noneho habaye. So, for how about the right lower lobe collapse? The right lower lobe collapse, without even reading this, it has the same fashion as the left lower lobe collapse. Do you remember how the left lower lobe collapses? Do you remember?
Yes, sir.
Yes.
So the right lower lobe collapses in the same fashion. Because it's a triangular opacity that's medially displaced almost near the shadow of the heart. Silhouetting of the right hemidiaphragm and a triangular density posterior-medially are common sign of right lower lobe atelectasis. Right lower lobe atelectasis can be distinguished from the right middle lobe atelectasis by the persistence of the right heart border. Remember, for the right lower lobe, the border of the heart is still there, but right middle lobe collapse, there is silhouette sign positive. Okay, but the fashion is the same as left lower lobe collapse. Look. If you see this, look, I still analyze still be systematic. Technically, it's not bad, it's not good, but it's cut off something. It's not deep inspiration. I can see maybe at 3, 4, 5, 6. Yeah, maybe deep inspiration. There is no much rotation, by the way, no much. But if I analyze the mediastinum very well, the heart is normal in size. But there is something here. There is a line before even I leave the mediastinum. There is this line. Why? What's going on? You see? This line and it looks like continuation of the cardiac shadow. And again, this part is more opaque than normal. Why is this too much opaque than normal? And immediately another thing, this distance, this difference in the location of the level of the hilum is too much. It looks like the right hilum has gone down compared to this. This left hilum, this one is down. And again, it looks like there is overcompensation of this lung, too dark compared to this. And again, too much compared to this. Look, this is how this lung looks like. And this one, it's like there is more air here. Those are the signs that can tell me there is something here that's not clear. And by adding this, you say, this most likely, this is right lower lobe collapse because of this shape, this well-defined linear opacity superimposed with the base of the heart. This is how now right lower lobe collapses. Any question here? Any question?
Yes.
But it is the same fashion as the left lower lobe. Okay.
Correct question.
Here go.
I can't find where the right heart borders. Is there any?
Right heart border, remember, look, this is the heart, this is the heart, and it was not supposed to come like this. It was supposed to go like this one. Apparently, it was supposed to go like this, and but here there is something. Even me personally, if I see this, I will not report as immediately as a right lower lobe collapse. I will immediately request for the lateral view, for sure. And lateral view will show it very, very well. That is right lower lobe collapse. But requesting right lower lobe, I still have it due to the findings I have seen. Okay. Komeze.
Yes.
Number 3, nuko washyizeho tuno dufresh kukira dushyize ariko if I analyze this chest radiograph, it's technically good. I don't see any problem. Though it was somehow under penetrated. That's the reason why it's the lungs are whitish somehow. They're not clear as we are supposed to be. It was supposed to be. And deep inspiration, I don't see deep inspiration. Something's lacking. It's not good in deep inspiration. There is no much rotation, apparently, even if there is, but it's not too much. The trachea is central. Apparently, the heart size is normal, considering even the lack of deep inspiration. But if analyze, the upper zone are good, zones are good, upper zone, the middle zone are okay, symmetrical. I don't see any opacity. Those are the vessels. But the lower zones, I see something. These are linear opacities. These are not vessels. I have never seen vessels being oriented this way. These are horizontal linear opacities here. And even on the right side, even if they didn't put something, but there are some, these are not vessels. This maybe this can be one, but this no. There are some linear opacities here. Those are not normal, those are not normal opacities, like vessels. I remember I told you that when you see linear opacities like this, think of either segmental or subsegmental atelectasis. Some segments were collapsed. And this is very common. Common, we see them commonly, and this is even the cause of pain. This can be the cause of cough and pain. Is it clear or not?
Clear.
Very clear, indeed.
It is but tough to find that linear collapse. Opacity. It's very tough to see that linear collapse.
No. No, I mean,